Hello and welcome to the latest in a series of NR Times Roundtable discussions. Today we're focusing on the future of stroke care, and I'm delighted to say that we have a really distinguished panel with us today, a group of experts who are ready, able and willing to share their insight and their views on the future of stroke care, as well as their considerable experience. So before we get into the main part of the discussion, I think it would be helpful if we understand a little bit about each of our panelists and their experience. So I'll ask each of the panelists to introduce themselves. I'm afraid I'm going to start with you, Marie, because you're first on my screen. So if you don't mind saying a little bit about yourself, your organisation and your areas of specific interest, Marie, that would be great.
No problem at all. Hi, my name is Marie Adams. I'm a physiotherapist by background, a neurophysio by background. I work at Circle Rehabilitation in Birmingham. We've got the first of its kind from a neuro rehab site. We integrate virtual reality technology into our therapies, and we have a full MDT team. We do outpatients and inpatients activity. And my biggest interest is looking at how we can integrate technology to better treat our patients, but also to make our services much more efficient and effective.
Fantastic. Thanks, Marie. And we'll definitely come back to talk a little bit more about technology and the role that it plays. Thanks for that introduction. Sandy, could I come to you next, please?
Yes, thank you, Alistair. My name is Sandy Gill. So I am also a nurse by background, but I'm currently working as the registered manager at Hamberley Neurocare. So Hamberley Neurocare is an independent provider of neuro rehabilitation services, and we've got sites across Hampshire, and we've also got a site up in Worcester. So one of the pathways that we do deliver is for stroke rehabilitation, and I'm quite passionate about that. My background's in stroke and neuro rehab. I've worked across independent sectors and also the NHS as well. So we've got a full multidisciplinary team, consultant-led service. We obviously offer therapies 5 days a week. So my I think areas of interest are really about equal access and opportunity for residents and patients at any point during their injury, and being able to open up that access to rehabilitation services after that point of, that finite 12-week window that we often say. There is much more after that to gain. That's what I'm interested in making sure that we're providing that. Thank you.
Fantastic. Thanks, Sandy. And Jenny and Tila from QEF.
Hi there, my name is Jenny de Canha. I'm the head of service here at the Queen Elizabeth Foundation, the Care and Rehab Centre in Leatherhead. We are a large 48-bedded inpatient rehab unit, although we do accept clients for outpatients and day cases as well. The bulk of what we do is neurological rehab. That can be intensive rehab, slow stream rehab, but we do also offer other forms of specialist rehab, whether that be trauma, orthopedic. We're currently developing a pathway in amputee rehab as well. We also take clients that have complex care needs and clients who may benefit from a period of respite. So we really do offer quite a diverse range of services, and we do have pathways to support all of that. We are a consultant-led service. Dr. Mamo is our consultant. We have a full complement of the MDT, including a 1 day a week in-reaching dietitian. We also have neurologic music therapist, and we partner with Chroma for that. And then across the spectrum of the MDT, obviously we have physio, OT, speech, psychology. We have a wonderful care and nursing team and a fantastic group of volunteers, because we are a charity as well. And today with me, I have got Tila. So I will allow Tila to introduce herself.
Hello, everyone. My name is Tila Akbar. I am the lead occupational therapist. I recently joined QEF. I am really interested in upper limb management and stroke rehab, wheelchair management, and splinting. That is basically my area of expertise. I have come in from an acute setting, so this is a different setup for me, but I'm enjoying it so far and really looking forward to learn from all the specialities today. Thank you.
And just
Great,
bring it back together from what Tila said in terms of my interest and, for example, having the skills of Tila working in the acute, bringing that into the rehab setting. It really is for us to be able to understand the client and their need and to be client-centred with our approach to rehab, so that we can understand what's of most value and importance to the clients, so we can really support them from that next step from inpatient rehab into the community. And that really is what the whole MDT here focus on, is that client-centred approach to rehab.
Great. Thanks, Jenny. Thanks, Tila. And last but not least, Ellie.
So hi, I'm Ellie. I'm a physiotherapist working for Odstock Medical. So we specialise in electrical stimulation. Obviously, my background says functional, but we also look at other forms of electrical stimulation, so NMES, as we can see it's in all the stroke guidelines, which I'm sure we'll cover later in today's discussion. I do have a background in community and inpatient stroke rehab, which is what I did prior to working for Odstock. So I can offer expertise in electrical stimulation, which is why I'm now working for Odstock.
Great, thanks, Ellie. Today we're talking about the future of stroke care, but I think to talk about the future, we probably need to spend a little bit of time talking about where we are now. So I'd like to go around the panel and ask each of the panel members where they think things are, the state of play, and maybe talk about some of the challenges and some of the developments that they're seeing, just so we understand where things are. And then we'll come on to talk about innovation, new approaches, and concentrate on the future. Maybe, again, going in reverse order, Ellie, I can start with you. If you could say something about where things are just now, any of the challenges, but it would be interesting as well to hear your thoughts on what excellence looks like in terms of stroke care as well. And then we'll just work our way through the panel. Apologies to you, Marie, because by the time we get to you, probably a lot of ground will be covered, but I'm sure you'll still be able to contribute your own thoughts. So Ellie.
So I think where we are at the moment is I think there's a huge battle with where funding is concerned, and particularly in services being limited in how much they can deliver stroke rehab and the longevity of it, because even the ICSS, which says we should be supporting stroke patients for up to 6 months, is even outdated. If you talk to Nick Ward at Queen Square, he's going, you can still see improvements much further down the line, which we can all see. I think where electrical stimulation has its place is that self-directed therapy. It's ongoing. To quote Nick Ward again, is that he actually said, why aren't we almost prescribing NMES for shoulder pain instead of giving out drugs all the time? Because we know it works. It's also evidenced in the current stroke guidelines. So where we are at the moment is actually not being able to deliver what we know should be delivered. In terms of time dedicated to rehab, supporting patients to be self-managing within their rehab. And I think what excellence looks like is being able to be a support for the long term, where patients can learn to take ownership of their rehabilitation. So you almost have that intensity at the start of their rehab, but also giving that like long-term input further down the line, which I think is what's missing at the moment. Often patients will talk about feeling abandoned, and I can see why.
Thanks very much, Ellie. Let's get the discussion off to a great start. Jenny and Tila, similar question to you. Where are things just now? Challenges, but also, what excellence looks like.
Yes, quite similarly, I think, to what Ellie said. I think funding does obviously create challenges, because funding is what provides us the resource to then deliver what's needed. And for me, we very much want to be able to offer the input and the interventions based on the client's needs, and sometimes the funding does not allow for that. And there are restrictions in terms of the length of stay that clients may have, and as a result of that, that almost directs the focus of your intervention. So for example, in an inpatient unit, we really want to be able to do thorough assessment, identify key impairments, and then create a treatment plan that will support those impairments and feed into the client-centered MDT goal. But if we are being sort of directed on a length of stay that's not as lengthy as possibly our assessment may indicate, then fundamentally the time we spend in restorative therapies becomes shorter, and the focus is more about supporting a safe discharge into the community. And actually, during that acute and subacute phase post-stroke, that's really where the literature guides us to be maximising on the restorative therapies, the repertoire, the practice. And as a result of funding restrictions, possibly on length of stay, that can make it a challenge. It doesn't mean it's impossible. We are a great MDT here. We like to have that approach that anything is possible. And sometimes we come together and scratch our heads and have to really think about that. But I do think that's where some of our excellence and the expertise from the therapists really comes to light, and that shines through. So for example, our physiotherapy team are very aware of the stroke guidelines with regards to cardiovascular exercise and ensuring that you treat clients post-stroke to work at an optimal heart rate, and trying to do that in addition to working on all of their other impairments, and actually being mindful of the fact that a client may have had a stroke, but their past medical history may also influence their ability to work at a set heart rate too. It might not always be the best for them at that time, but what my physio lead, Ellie, has put in place with her team is a cardiovascular exercise group where clients that have had a stroke and who have been referred and are deemed safe, where there's no contraindications in place for them to attend the group, they're able to do that in a group setting in addition to having their other one-to-one therapies where they can be more impairment focused. That's one example of the team trying to take the guidance in the literature and offer that excellent service, even where we have constraints, for example, on length of stay. It's not always easy and it's not always doable, but certainly the efforts are there. And I think that's wonderful to see within the team. I'm going to hand over to Tila now, because she might want to add some of her thoughts too.
I think I will agree with Jenny, as we are basically working as a client-centered approach and every client is different. So at times we've got client with post-stroke fatigue, and it's been like really early ages, early stage of their stroke. It's been really difficult to engage them during the therapy session. That's why we are focusing them having in a group setting, so they may be engaged more in a group setting, but length of stay could be a real challenge where we don't know, and then we are focusing more onto the discharge planning and safety netting them back into the community, and then what happens after that.
Thanks, Jenny. Thanks, Tila. That's really helpful. Sandy, same question to you. Where are we? Challenges and also, excellence and what it looks like.
Yeah, no, I'm echo what Ellie, Jenny, and Tila have all said. Actually, I think funding is a big part of this, because we've got some excellent clinical guidelines, as we know, that give us what excellence should look like, really. And I think that's an achievement. That's really good. So I think there's been some good movements in that over the last couple of years, and some good input into the guidelines, the stroke guidelines. I think one of the things is how do we match that? So yes, funding is an aspect of that. Looks like we've got the drive. Everyone around the table here is, quite expert in working in organizations and being able to deliver that and having the want to deliver it. But it's how do we get the resource? And it's not just resource, it's also about streamlining services. So looking at, different providers and how we can kind of come together and work together as a collective to be able to be that patient-centered, needs-based, and deliver that. And one of the things that the clinical guidelines discusses is that rehab, we shouldn't be talking about rehab potential, and rehab potential can be potential at any point after someone's had a stroke. And I think really being able to tap into that and being able to deliver that is what excellence should be and what we should be striving for, I think, in the future, near future. So I think, we at Hamberley Neurocare, we have, we've got a full multidisciplinary team. We do take patients at any point during their injury. And we have seen those improvements. We've seen it with the intensity being offered to them being able to access, rehabilitation after, say, a year after having their stroke. And they're leaving us far more independent and far more having that increase in quality of life that they would have had, say, if they, wouldn't tap back into it, to having access to those resources. So I think a collective approach is needed, not just from funding, but also kind of looking at resources, where we have resources. The postcode lottery is one of the things that we often do talk about. If you live in a certain catchment area, you're going to have access to more. But really, I think it's about top level, how do we look at working better together and enabling that needs-based, patient-centered approach to care, which I think is so fundamental to recovery and is going to help to decrease dependency in the community in the long run.
Thanks very much, Sandy. Marie, as I said, I know we've covered a lot of ground, but I'm sure you have your own perspective on excellence challenges and where we are at the moment.
Yeah, it's very much, I echo everything like everybody has said before. There have been a lot of challenges, and I think COVID brought even additional challenges. So a lot of acute hospitals lost their rehab spaces, so they're trying to deliver rehabilitation on a ward setting, which isn't always the best environment for that. And we've also gone through a stage of workforce shortages as well. So yes, we do have to look at our workforce in a different way, and then we have to work in a completely different way as well. A lot of people are being discharged quite early because of the fact that there isn't that, and I can't remember who it was that said on the panel that it's more about looking at the acute stages of getting them better, patching them, fixing them, and then trying to get them to the next stage. And actually there isn't that focus on rehabilitation at the early stages, which is when we need to really capture that time frame. There's inconsistent access to services from a geography point of view. So depending on, like, if you live in a rural area, you'll probably get less access to services. But also, just there is the disjointedness around the care pathways. So when you're discharging someone home, you actually often struggle to gain the support from different teams because they have different criteria. So it's not really necessarily well coordinated. And then again, like everybody has already said, there's a lot of funding constraints. Rehabilitation costs money, and especially if we're going to be looking at, we require specialist knowledge and experience within our teams. And there's just not a lot of mental health support as well. And that's really, really important for our patients, not just the patients themselves, but also for their families as well, because it's a massive change for them. And I'd probably say, if I look at excellence, it would be all of the opposite of all of those things. So it would be all of the things around patient-centered approach, things happening in a timely manner, a full MDT, which includes the biopsychosocial aspects of their rehab. Sorry, the light's gone off. Which is grounded in evidence-based practice as well. And then just to have that consistency throughout the different stages of their rehab. So like everybody has already said, rehab should be starting at its very early stage, but actually there isn't a defined period where you can say you're never going to make progress. And so I always say to any patients that come through our doors, never say never. And I think you have to kind of give them that hope, but also maintain that realism in terms of we need to give them like small steps for that. But yeah, I think it's a lot of funding, integrating the support systems, as well as for coordinating the discharge afterwards, and so that they can have and see as well what progress they make in the future.
Thanks very much, Marie. It'd be interesting to open up the discussion now, and I'll just ask panelists to give me a little nod and I'll bring them in to talk a little bit about the role of education and awareness and the role of families as well, and their perspective on the kind of care plans that you're developing and delivering with those suffering from strokes or the after effects of strokes, and education and awareness in terms of the wider community as well, and the needs of stroke patients. So if I can open it up to talk about education, awareness, the role of families, if anybody would like to come in. Jenny, Tila?
Really good points, and I think they're hugely important. As I said earlier, client-centered rehab for us is sort of the top priority, but that client then has that sense of belonging, and that belonging is directly to, for the majority, their family. And dependent on the type of stroke and the impact that stroke has had, we realise the dynamics within that family can really shift, and that can be a real problem and a real challenge. And I think we also get clients in a rehab setting that come to us after a hugely traumatic and difficult time. Strokes typically come unexpectedly, and you have families that are still in that state of shock. They can't quite understand what's happened. Then you have the client themselves, how they are adapting and feeling at that point in time. Does everyone think they're coming to rehab? That's a quick fix. We're going to return to the pre-stroke person, as opposed to actually you now have a life-changing condition that you have to manage and going forward. And of course, there is a spectrum of what that might look like, and everyone's different, and that will evolve along the way. And actually trying to dual plan and dual manage expectations with clients and family members is really difficult. And I think it's something that we're constantly working on, trying to get better at, but really pulling in the family members and those loved ones into those discussions as early on as possible to understand what's happened to their loved one and how we expect things to change as time goes on, and to try to really understand what is of most value and what is of most meaning to that client that we can really help with, because we are there to support and help, but we cannot fundamentally fix. So it's thinking about that. People then typically do come to rehab. They love to be here. They get that sense of belonging. They get that sense of achievement. They can see and they can understand the aspirations that we are creating and working towards. But there does then come a very sudden, blunt end point. And that can then create another set of emotions and anxieties and concerns and thoughts. So for us, we've really understood that piece about continuity into the community, not just for the clients, but the family members, is fundamental. So we really try to work with our psychology team here, with the client and family members where appropriate, in terms of that education piece and in terms of what life might look like and going forward. But we've also partnered with Headway and Stroke Association, because we recognise the anxieties that can present for everyone within that network. When it comes to discharge, and what we don't want is for that client to drop off the cliff, so to speak, once they leave our rehab centre. So we have actually set up in service for Headway and Stroke Association to come on site and meet our clients before they discharge. They also meet the family members, should the client consent to that. And it's an opportunity for that face meeting and to almost eliminate some of the unknowns and anxieties that might present. Because once one leaves this unit where they've got 24-hour care, they've got therapists, they've got care staff, and then they're sat at home, possibly alone, that's huge. That in itself can be quite catastrophic for some people. So trying to set up a network and a connection in advance for us is really important. And that partnership we've got with Stroke Association and Headway has proved to be hugely beneficial for that piece in terms of continuity and discharge and transition into the home. Again, we similarly try to work in that way with the community therapy teams where possible, particularly if it's more complex. We will do those joint assessments at point of discharge. We think that's really important. But just as I think maybe was it Marie that mentioned, it is a bit of a postcode lottery. Not every community service has the same provision and is able to do that. We have got a contract with East Surrey, And we do take clients from East Surrey with a stroke, and are very fortunate that we have quite an established relationship with their community services. So it allows us to work very closely together and ensure some of those transitions and handovers are done. But for clients that possibly live further afield, that may not always be feasible, and that can become a challenge. I don't know if there's anything you want to add to that.
Yeah, I believe family involvement is very important early on. That is why we usually take the social history from the family, what the patient likes to do, as we want to give them the holistic care, being a client-centered approach. And then we do very early on family meetings where we will come together as a team. We will discuss the impairments. The client is always attending the meeting as well if they want to. Discussing the goals around their rehabilitation journey, if there is something which is very important for them and they want to explore that area, if possible, if we can work on that. So yeah, over here in QEF, we really believe family involvement is quite important, so we can hand it over post-discharge also to the family and how to look after their loved ones.
Thanks, Jenny. Thanks, Tila. Would any of the other panelists like to come in? Marie?
Yeah, thank you. So, yeah, families would often say that they, again, like what Jenny and Tila said, they feel like they've fallen off a cliff. We have rehabilitation here as inpatients, and it's intense rehab. And so when they finish that, it's nothing like that in the community. So we do try our best to try and soften that a little bit more. So we do, like yourselves at QEF, we do regular meetings with the family members and the patients involved, so that throughout the whole rehab journey that they are with us as inpatients, they are fully aware of the impairments and also what maybe home might look like. We also, depending on the geography in terms of where they've come from, we will do some integrated sort of home visit, access visit type sessions. So we might take them home for a couple of their sessions and see how they manage in their own environment, because it's great that we have all the facilities here, but we can never sort of recreate what it's like in their own homes, and they're going to come up with challenges that they were not aware of before once they're discharged. So we try and soften that a little bit by doing that. We also here offer home leave. So once the therapy team are happy and the medical team are happy from the point of view of medication, we will kind of arrange periods of time where they can go home over the weekend and just sort of find out what it's really like to be at home. And even sometimes it might be a couple of hours, and other times it may be overnight, to see how they manage overnight. And I think that really helps our patients and the family members. Kind of, they come back and they will feed back to us like, we had a challenge here and we weren't expecting it, or also potentially that everything was really, really good. Families become informal carers. They've got no training, no emotional preparation for it, and actually there's often a lack of support for respite available as well for them, and so they feel underprepared for it. And you probably would, because like Jenny and Tila said, it's really unexpected when you have a stroke. You wouldn't have expected it to happen, and there's other factors that come into play, like the managing of behavior and emotions and the change within their loved ones. They're almost sort of, we try to make sure that the family members do not end up having to change their role within their family network as well, which is always really, really challenging, because they want to support them, but equally they need to be they're their loved ones, they shouldn't be their carers. And just generally navigating a complex healthcare system is really tricky for us as clinicians, let alone for the family members. So we do have Headway involved with us as well. They come to us and actually base themselves on site once a month, so they can meet the families and have those open discussions and conversations around what might be available to them. And one of the biggest other things I would probably say is the financial challenges that they face, because this loved one potentially was working before, and they're not able to contribute to the household income anymore. And then you've got the additional costs around care and support in the home environment. And often the resources are so stretched that people then try to look at, well, how can we get private physio to come out and see our loved one in between times? So the finances just becomes a bit unmanageable for them. So I think a lot of it is around that unawareness and being able to be prepared for the unknown, essentially. So we try our best to soften it, but it is really difficult. And it's interesting, Jenny, that you would mention the terminology of falling off a cliff, because actually that's exactly how it feels to them. They feel as though they've literally been dropped off a cliff, and they feel dumped in the community environment, waiting for something to happen. So yeah, I would say that they're the biggest challenges that they would face as family members and patients.
Thanks, Marie. Ellie, and then I'll bring Sandy in. Ellie.
So often in like the FES services, obviously we've talked a little bit about kind of postcode lottery, and that happens with funding. So often areas will only fund for foot drop, and we know that electrical stimulation can do so much more than that. But obviously then not all areas do. And that's a real pressure on systems, on orthotic systems, in terms of like patients as well. Particularly, I don't know if everyone else would agree with this, but particularly since COVID, in my experience, we've had a lot more working age strokes than we would have seen previously. So you've got young families, you've got children that are obviously seeing their parents in a very, very different light. And often you're doing these funding requests which may not get approved, and you're thinking, but they just want to play football with their son, which is a huge goal. And it does feel like sometimes it's like a battle, because, you know, if they just lived 10 miles up the road, they'd be funded, which is ridiculous. And it really does come down to that lack of parity across the country, where neighbouring ICBs don't necessarily, one will fund, one won't. One will have extremely good community support services afterwards. The next neighbouring one doesn't. We've also got the charities around. So we've got actually an association with Different Strokes, because Different Strokes does support more of those younger strokes. But although the Stroke Association still does an amazing amount of work in support groups around as well. And it's just like the challenges that are going beyond, because obviously sometimes we're seeing patients much further down the road. So they've effectively, as you've quite rightly said, fallen off that cliff, and they don't know where to go next. And that's such a big challenge, is that it's like a sea of what do we do? How do we get back to work? There's also a lack of vocational rehab services around, which is they are starting to expand. Again, those 2023 stroke guidelines have been really useful for helping set up services, but it's still not enough. And we also know in the current state of things that a lot of NHS trusts are pulling back on staffing on certain services. So it's like where we want to see a growth in excellence, we're also going to be facing a huge kind of change in the way systems are working going forwards.
Thanks, Ellie. Sandy.
Yeah, no, thank you, Alistair. I just wanted to comment on just the managing expectations and that bit that we, is so important, and not just for our patients, but also for family members, and involving them right from the early stages. So right at the onset. So it's one of the things that we do at Hamberley, is making sure that families are very much involved in setting those goals and being a part of that, because then they do feel like they're a part of that journey. And that's part of them kind of understanding and recognizing what is it that, my loved one needs to work on, and, how are we going to get there? So I think, oftentimes, not intentionally, but unintentionally, their needs can be ignored in the, after a life-altering injury for their loved one. That new norm has changed and shifted in so many ways, in so many different aspects. So I think support for families is so integral, and making sure that they're involved in that education support is really set up right from the beginning. So that's one of the things that we do really well, actually. And we're quite fortunate at Hamberley. We've got, beautiful, beautiful building, en suites in each of the rooms. We've got a rehabilitation apartment, which we can actually, one of the things that we do is closer to discharge, we can allow our loved one with their families to spend time in that apartment. So he's still got nursing care around and that support, but it's that one step closer to being ready for discharge. And it really gives them that independence and that feel for that. So I think really understanding what it is that's important for families and getting them to be involved in that and being very much a part of that journey of recovery for that person, I think is something that, we do need to do a little bit more of.
Great, thanks, Sandy. A positive future for stroke care obviously depends on innovation and new approaches. I'm really keen to hear from the panelists about examples of innovation and new approaches and developments that are promising for the future of stroke care. So again, if I can open it up and just ask panelists to give me a nod, I'll bring you in to talk about examples of innovation and new approaches and developments. Ellie.
So in terms of developing, obviously, we know that we've got certain devices for electrical stimulation. And one of the things that we're developing to kind of make it more specific to rehab is having a triggered electrical stimulation whereby, so obviously our walking stimulator is triggered by a foot switch, but we're looking at more kind of that upper limb sort of trigger. So you've been able to do those sort of grasp release type works. You can then involve it within things like CIMT and lots of more specific functional task practice, because we want to obviously retrain movement in a good wave of patterns. You also then could potentially integrate it into a lot of like virtual reality is becoming a massive thing in neuro rehab, which is engaging. I know in my previous role, one thing I like to use was something like grippable, because it's boring to do, say, 10 wrist extensions. And by playing a game, people do so many more repetitions and they want to beat themselves every single time. So, and in fact, you could assess yourselves with it as well. So I think in terms of advancements in technology, electrical stimulation very much has its place. And we are working with those advanced technologies now.
Great, thanks, Ellie. Marie, you mentioned technology, and then Jenny and Tila, I'll bring you in. Marie.
Yeah, so as Ellie said, so at Circle Rehabilitation, we are able to deliver the intensity that is required because we do have access to a lot of that technology. So we are using a lot of robotics. We use VR, augmented virtual reality, as well as integrated virtual reality. And like Ellie said, patients can be competitive against their own previous scores, but also you can bring two patients together and they can be competitive against each other as well. It's really engaging. They're fully immersed within it. They don't even realize that they're doing rehab. And for some of our patients, they wouldn't have normally have gone to the gym and done exercises. It just makes it much more stimulating and enjoyable for them. And at the end of it, the outcomes are huge, because a lot of this technology is able to churn out a lot of the outcome measures in kind of pictorial graph pictures. So they're able to see how they have improved, because I think that sometimes is a bit of a challenge. There's a lot of AI improvements as well, so it can track people's progress. And also, if we're able to in the future integrate that within the care plans, as well as within their therapy, it can almost sometimes predict what is able to be achieved. I think, yes, it will not take away the expertise of our clinicians, because you do need to often prepare them before they go on these pieces of equipment. But also, you need to be able to supplement their rehab with it. It's just a way of delivering the intensity that you require, especially with the workforce challenges that we have. Things like exoskeletons can help with that ability to be able to do something in that upright position, or de-weighted support equipment. You can allow yourself to stand back and have a look at what's happening and analyze what's happening in someone's gait pattern, or even just their functional movement, so you can make those adjustments as a therapist. So the technology that we have available at the moment, and also the growing technology in the future, can really help. I think the only thing that we need to be mindful of, because there's lots of tele rehab as well, so a lot of the virtual reality equipment you can use in the patients can use in their own homes and can be tracked by the clinicians. It's just making sure that we are also making sure that everybody has that ability to have that, because we do have some patients that probably wouldn't be able to access it if they didn't have a family member that could support them. More of the older generation, some of them wouldn't know how to use them. So we just need to make sure that we're providing access to all when it comes to using technology for rehab, so that everybody has that opportunity.
Great, thanks, Marie. Jenny, Tila.
Hi. Yeah, I mean, I think this is a really, it's really, interesting topic point. Because for me, fundamentally, that centre of excellence needs to offer that diversification of treatment interventions, because no one size fits all. No two people are ever the same. No two strokes are the same. No two people have the same past life, past interests. And actually, even if you find two people that have a very similar type of injury, it doesn't mean their aspirations and goals are going to align either. So I think it really comes back to that, having the expertise and the knowledge to do those thorough initial assessments. Yes, identify those key impairments, but then bringing it back to an open, authentic discussion with the client and their family about what is it they want to achieve and in what timeline, so then that we can really think, well, what is the most appropriate treatment plan and rehab prescription to offer you, and why, and to be able to ensure we monitor that through various segments along the way, making sure we come back to those goals, we come back to those outcome measures, make sure we're presenting understandable outcomes to clients, and that might not always be data. It may be a video, it may be a photograph, it may be a scoring, a rating. There's many ways in which we can do that, but I think it's making sure that however we are providing treatment to our clients and interventions, that they fully understand the purpose in which we are doing it and why we're doing it. So for us, conventional therapies are there, and that is usually a core. And that is usually what the majority of our therapists will come in and have the skill set and knowledge to be able to deliver and really get great outcomes. But again, we're seeing clients that can present with impairments across multiple domains, with complex past medical histories. And so it is important to have that diversification of treatment interventions. And that's where then that really, for me, creates that scope for more senior expert roles and specialisms. And for us, we do offer that FES. We can do the soft and, the splinting, thermoplastic, Scotch splinting. Again, it's the same with robotics and technology. We have got the time of motion here in our service, and it's been a wonderful addition to our treatment adjuncts that we can offer. It allows that repertoire, that intensity. It offers an alternative to those clients who might not like that conventional therapies. But there is also that element of fun. There's that element of cognitive treatment that sits within that. So again, it's thinking about, is that treatment more superior to another treatment and why? And I think that's where it's really important to have that MDT meeting regularly, for those rehab planning meetings, to be reviewing your treatment plans, to be reviewing your rehab prescription. Are we on track? What modifications do we need and why we need that? Because I think for us to be able to deliver those good outcomes in that efficient way, we need to constantly be reflecting on our practice and questioning ourselves with curiosity as to what we can do and do differently in order to be able to get that client to that end goal. So for me, innovation comes in many forms, but again, client being at the centre of that alongside that goal.
I think that's really you now.
Thanks, Jenny. Sandy, thoughts on innovation and new approaches?
Yeah, no, I agree with what everyone's saying. I think, having that approach be tailored to the person is really important again. So I do think, looking at the traditional ways conventional ways in which we deliver therapy, but then also adding those adjuncts to make sure we're enhancing the outcomes for our patients is really important. And kind of getting away from that traditional kind of boxed approach of rehab sessions, for example, but looking at kind of a 24-hour, 24/7 approach to rehabilitation, 7 days a week, and who's delivering that. So, yes, you've got your experts and you've got your therapy team, but also care staff. So we've got life skill specialists, which are similar to rehabilitation assistants, that carry on from and are able to deliver those sessions. So you're getting that intensity of therapy. That's you can be flexible with that. So not necessarily someone that's, say, having a bowel care routine or a morning routine, so that can get interrupted often and can feed into a therapy session, but being able to be flexible and kind of what works for this person and at what time, and who is it being delivered by. And then that way it gets away also from that kind of boxed thinking of, okay, this is the time for a therapy session, now I'm just going to go back to bed to rest. But no, what can we do all around and make it fun, make it interesting, and make it engaging for that person, because that's probably what they want. But again, it goes back to what's important for that person. How do you tailor that approach? And I think that's really, really key and fundamental.
Thanks, Andy. I'm going to start drawing the discussion to a close now, because we've covered a lot of ground. The subject matter we addressed today was the future of stroke care. So I'd like to ask each of our panelists for their final thoughts on not just the future and what it might look like, but where they see change, improvement, and progression coming from. If there was one or two things that they thought promised an even better outlook and an even more positive outlook for the future of stroke care, what would those changes, improvements be? Where's the next wave of development going to come from? So final thoughts, sound bites, if you like, on the future of stroke care. Sandy, since we spoke last to you, I hope you don't mind me kicking off with you.
No, it's a very good question, actually. And I think a bit about everything that we've been talking about today is really what we need to look at in the future. And I think, being able to, one of the things that I mentioned early on is that that rehab potential, and recognizing that there's potential for everyone at every stage. And I think that is where the future of stroke care should go. We've heard a lot about technology. We've heard a lot about, Ellie's mentioned a lot of things, and where you can see outcomes and those changes down the road. And I think being able to recognize that, and being able to get the funding. And that's, I think, one of the other key things we've been talking about is securing that funding. And I think getting the right people, our governing bodies essentially, on board with this and understanding the importance of it. So them really, understanding what would be the reason to do this, right? And I think that's where research is really important. So I think we do need to probably look at that. So what is stroke research saying? Doing a little bit more in publishing outcomes and showing this, and showing how outcomes are changing. They are changing year after stroke, even surpass that. And what does that do for longer term in terms of health and well-being and disability? And, I think those are the types of things that we probably need to look at for the future of stroke.
Great. Thanks very much, Sandy. Ellie, your final thoughts on the future and where change is coming from?
I think in terms of future, it'd be great to see a lack of postcode lottery. It'd be good to see everyone across the country being able to receive the same care at the same points in time, because it's so unfair. If you could be if you were just 10 miles down the road, for example, to a different area, and you'd have a completely different set of treatment. So I think the future needs to align it across the country, and to go, everyone should be getting the same care at the same time, obviously looking at the patient's goals. So the patient's the center, but they shouldn't have to think, oh, I'm going to have to pay for one thing where somewhere else would get it funded, because everyone's entitled to equity rather than equality, to the things that they require, because everyone's going to require slightly different things, particularly if you think of age. A retired person is not going to want to return to work, whereas someone who is working age might actually, they need the access to be able to look at those long-term goals and aligning with that, because as I said earlier, we are seeing more younger age and more working age strokes, and we want a healthy workforce at the end of the day. So you're also looking, the future is not just the rehabilitation, but also that stroke prevention as well. What can we do to maintain positive changes in the world of stroke? So that's my final thoughts.
Great, really helpful, Ellie. Jenny, Tila, final thoughts?
Yeah, I think that reintegrating them back into the community, we are very lucky that we have a mobility center, QEF Mobility Center in Carshalton. So if a client was driving post-stroke and they want to resume it after their stroke, so we can refer them over there, and the center, the mobility center, can assess their driving skills and all of that. So I think the future of stroke will be reintegrating them back into the community, and what Ellie said, equal opportunities for everyone. It is a bit difficult when for discharge we are ordering equipment, a certain area we can order certain equipment, and for another area we cannot order that part of equipment, which make it very difficult for us and for the client as well. So equal opportunities for everyone. I think that is the one from my end.
Yes, and I think from my end, it's sort of been touched on a little bit already, but I think fundamentally, I think there needs to be some serious discussions with regard to the recognition of stroke being a life changing condition. And whilst, yes, there may be some evidence regarding the early phase of rehab to tap into some of those more immediate plastic changes, that potential changes, and there is evolution with that. And I think there does need to be more recognition to how we can support stroke survivors to access rehabilitation based on a need and a decline in functionality, and looking at the risks of where one becomes almost socially isolated as the result of having a stroke, and preventing how that can occur, because that can really have quite serious ramifications. And I think trying to pull data that sits within the community, I think, is a really big part of that. And I think that would be a really difficult task. And whoever was to undertake that, I think that would be a challenge. But I think that's really important, because I don't think we can shape the way forward clearly if we don't really understand where the current gaps are. And I think for us, that there certainly seems to be a sense within the group that there is that provision in those early stages, but those early stages of rehab are quite fraught with other medical demands and the psychological impact that comes immediately post a certain trauma, but it doesn't actually represent the real future of what life with a stroke might look like and going forward. And I think to enable that person to have a life that's of meaning and value, that needs to be picked up first.
Great. Thanks, Jenny. Thanks, Tila. And Marie, you get the last word.
Okay. So I think investment in the rehab infrastructure needs to happen. There needs to be policy change to extend the rehab timelines that we currently have, and also a cultural shift to look at stroke as a long-term journey rather than something that's quite short-term from a rehab point of view. We need to make sure that we empower our patients and our family members as well, because they play a huge part in this rehab, in their own rehab journeys. And we need to look at how, and then I know, like Jenny said, we can't solve everything, but seamless integration within services. So integrating social care, housing and health as one, because you can't deliver a full holistic approach until you have all of those aspects put together. there needs to be more neuropsychology and cognitive rehab, and like I think it was Ellie had mentioned before, vocational rehab, because there is a lack of that. And like you said, we're seeing a lot more younger strokes coming through that actually they want to have some meaning to their lives after that post-stroke. And the whole thing around having universal access to high quality stroke services, it should be across the board. It shouldn't be that it depends on what area you live in or what location you are geographically, that you will have something completely different to somebody else. So I think they are massive. Oh, and also workforce challenges as well. So just looking at it from the bottom up, so from education through to actually there's evidence to say that there are people graduating, particularly from physiotherapy, and then there are no jobs. So again, that comes from the funding aspects as well, and looking at stroke and neuro in a different way from a policy perspective, government side of things.
Thanks, Marie. Well, there you go. I think those final thoughts represent a manifesto for a positive future, for the future of stroke care. On behalf of NR Times, I'd just like to say a very sincere thank you to all of our panellists for sharing their thoughts, experience and insight. It's been a fabulous discussion covering some profoundly important topics. And for all those watching, please share this as widely as possible. It really does deserve to be seen by as many people as we can reach. So once again, thank you to all of our panelists and to all of those watching. Thank you.
Thank you.